Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, a prospective study of Gallium-68 dotatate PET-CT for detecting gastroenteropancreatic neuroendocrine tumors and unknown primary sites, by Sadowski et al. My name is Jonathan Strasberg, and I am an associate professor at the Moffitt Cancer Center in Tampa, Florida. My oncologic specialty is gastrointestinal and neuroendocrine cancers. The diagnostic imaging of neuroendocrine tumors poses unique challenges. Conventional single-phase CT scans often lack sensitivity for detection of liver metastases, and most guidelines recommend multiphasic imaging protocols. Moreover, most well-differentiated NETs are poorly visualized on FDG PET scans due to their relatively low metabolic activity. On the other hand, radiolabeled somatostatin-receptor scans play an important role in the staging and characterization of NETs because they enable whole-body imaging and in vivo assessment of somatostatin receptor expression. This has important implications for the use of conventional and radiolabeled somatostatin analogs. Somatostatin receptor scintigraphy, otherwise known as octreoscan, was first developed by researchers in Rotterdam in the early 1990s by radiolabeling octreotide with indium-111, a gamma-emitting isotope. The scans were subsequently improved with cross-sectional SPECT imaging, and more recently by fusion with CT, enabling correlation of functional with anatomic imaging. However, despite these technological advances, the quality of many octreoscans remains poor, and their ability to detect tumors smaller than 1 centimeter is quite low, even with high-quality scans. Moreover, high rates of false positive findings occur due to elevated levels of isotope concentration in the bowel, among other factors. Octreoscans are also fairly cumbersome to patients as they require imaging 4 hours, 24 hours, and in some protocols 48 hours after contrast injection. As a result of these limitations, the role of somatostatin receptor scintigraphy in the workup of NETs remains controversial, and certain guideline organizations, such as the National Comprehensive Cancer Network, do not endorse baseline octreoscans as a consensus recommendation. The past decade has seen significant advances in somatostatin receptor PET imaging using the positron-emitting isotope Gallium-68. Various Gallium-68 peptides have been developed by conjugating the isotope to somatostatin analogs using DOTA as a chelator. Somatostatin analogs tested include DOTA octreotide, thus called DOTATOC, DOTA NAL3 octreotide called DOTANOC, and DOTA octreotate called DOTATATE. The DOTATATE peptide, which has slightly enhanced affinity to somatostatin receptor subtype 2, has been increasingly used in recent years, particularly in Europe. Multiple studies, largely retrospective institutional series, but also small prospective studies, have demonstrated significant improvements in sensitivity and conspicuity of lesions compared to octreoscan. Moreover, some studies have demonstrated that these advances lead to changes in patient management in a substantial percentage of patients. With this background in mind, the prospective study of Gallium-68 dotatate PET-CT, reported by Dr. Sadowski et al., represents an important validation of this novel imaging modality. This study enrolled 131 patients with neuroendocrine tumors either known to originate in the gastroenteropancreatic tract or of unknown primary, as well as patients with suspected carcinoid syndrome but negative conventional imaging studies. These patients underwent imaging with Gallium-68 dotatate PET-CT as well as octreoscan SPECT CT and multiphasic CT or MRI scans in a blinded fashion. The primary outcome was the detection of lesions by each imaging study. In order to assess sensitivity, the denominator was the total number of lesions visualized in all 3 imaging modalities. The results of the study strongly favored the Gallium-68 PET scan, particularly in comparison to octreoscan, Gallium-68 dotatate detected 95% of lesions with an average SUV max of 65, corresponding to 747 out of 891 total lesions identified by the imaging denominator. This was significantly higher than CT and/or MRI, which detected 45% of lesions, and Octreoscan, which detected only 31% of lesions. In summary, 422 lesions were detected by Gallium-68 dotatate that were missed by both Octreoscan and CT-MRI. In 14 patients with unknown primary tumor, the primary lesion was detected on the Gallium-68 scan. Among 25 patients who had hormonal-related symptoms and biochemical evidence of NET with negative radiographic workup, Gallium-68 detected lesions that were negative by Octreoscan in 7 patients and that were negative by CT-MRI in 3 patients. Among 25 patients who underwent surgery with intraoperative assessment of lesions, Gallium-68 was found to have detected 64% of lesions compared to 22% with Octreoscan and 39% with CT or MRI. Perhaps most importantly, the Gallium-68 scan led to change in management recommendations in 1/3 of all cases. Although the specificity of Gallium-68 dotatate cannot be precisely ascertained from this sort of study, there have been few indications of significant false positive readings in this study or in other studies in which patients subsequently underwent operative evaluation of lesions. We can therefore infer that the Gallium-68 scan offers a high level of both sensitivity and specificity. Other advantages of Gallium-68 over Octreoscan include convenience to patients and lower levels of radiation. The recently presented results of the Phase 3 NETTER-1 study, which demonstrated clinically and statistically significant benefit of lutetium dotatate in midgut nets, will likely lead to approval of radiolabeled somatostatin analogs as a standard net treatment in the near future. This development can only enhance the importance of somatostatin receptor PET imaging. Levels of radiotracer uptake on Octreoscan are already proven to be predictive of response to radiolabeled somatostatin analogs. It is likely that the Gallium-68 scan will be even more predictive of response to radiolabeled somatostatin analogs, particularly to lutetium-177 dotatate, which uses the exact same somatostatin analog to deliver a therapeutic rather than a diagnostic radioisotope. Precise standardization of SUV uptakes that correlate with response will enable the Gallium-68 dotascan to serve as an ideal companion diagnostic for radiolabeled somatostatin analog therapy. In summary, the future looks bright for Gallium-68 somatostatin receptor imaging, particularly the Gallium-68 dotatate scan. It is unlikely to supplant conventional cross-sectional imaging in the standard follow-up of metastatic and/or surgically resected NET patients, but is likely to be increasingly utilized in several important settings. These include 1. Evaluation of patients with hormonal syndromes suspicious for underlying NET but negative CT or MRI. 2. Baseline evaluation of patients with no NETs to enable full-body staging and assessment of somatostatin receptor expression. 3. Identification of occult primary tumor in patients with metastatic disease. 4. Preoperative assessment, particularly when aggressive surgical debulking of metastases is contemplated. And 5. Assessment of likelihood of response to radiolabeled somatostatin analogs. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.